The microscopic examination of thyroid parenchyma obtained during postmortem analysis frequently reveals autolytic changes that can confound the histopathological diagnosis if not properly distinguished from true intravital pathology. In this hematoxylin and eosin stain section, the most prominent feature is the widespread sloughing of thyroid follicular cells into the follicular lumens. These cells, which normally form a tidy cuboidal or columnar epithelial lining resting on a basement membrane, have detached due to the degradation of intercellular junctions and adhesion molecules following somatic death. This process of autolysis is driven by the release of intracellular hydrolytic enzymes from lysosomes, a process known as self-digestion, which occurs more rapidly in tissues with high metabolic activity or those containing significant enzymatic concentrations. The thyroid gland, being highly vascular and metabolically active, is particularly susceptible to these changes. Unlike the orderly architectural disruption seen in papillary thyroid carcinoma, where cells exhibit ground glass nuclei or orphan Annie eye appearances and psammoma bodies, autolytic cells show nonspecific nuclear changes. These include pycnosis, where the nucleus shrinks and becomes intensely basophilic, and karyorrhexis, where the nuclear chromatin undergoes fragmentation. In some areas, karyolysis may be evident as the chromatin fades completely. The colloid within the follicles may appear granular or unevenly stained, losing its typical smooth, dense, eosinophilic consistency. This must be differentiated from the scalloping of colloid seen in Graves' disease, where increased activity of follicular cells leads to peripheral resorption vacuoles as they rapidly endocytose thyroglobulin for conversion into triiodothyronine and thyroxine. Furthermore, the absence of an inflammatory infiltrate, such as the lymphocytic nesting seen in Hashimoto thyroiditis, or the multinucleated giant cells and granulomas of de Quervain's subacute thyroiditis, confirms that these epithelial changes are postmortem artifacts rather than a true thyroiditis. The stroma may show edema, but the lack of fibrin deposition or leukocyte extravasation helps the pathologist rule out acute injury. Understanding these artifacts is critical to avoid misidentifying sloughed cells as the papillary projections of a malignancy or the cellular debris of necrotizing processes. While the architectural integrity is compromised, the underlying thyroid structure remains recognizable, allowing for the exclusion of systemic diseases that might have affected the gland prior to the cessation of life. Final recognition of autolysis depends on the global nature of the changes throughout the entire specimen.